So our goals here are to review the prevalence of low back pain and variability of spinal imaging in the emergency department. And I'd like you to understand what constitutes complicated versus uncomplicated low back pain and when imaging is indicated. And we'll go through the ACR appropriateness criteria to understand better what imaging to order in these patients. And I'd like you to be familiar with the causes and imaging findings in patients with complicated low back pain. So for low back pain, this is a top 4 symptom for patients presenting to the emergency department, and 84% of us at some point in our lives will have back pain. And uncomplicated acute low back pain is defined as back pain lasting less than 4 to 6 weeks, and it's often nonspecific in nature, so it'll be localized pain in the back with or without radicular symptoms. And this is typically a self-limited condition. Most of the time, this is due to something like a muscular strain. And the appropriate treatment is conservative therapy with rest, PT, physical therapy, and NSAIDs. And imaging overuse is a huge problem, as we know, and it's a driver of healthcare costs in our system. There's tons of variability in terms of who gets an MRI when they present to the ED with low back pain. You can see if you're in West Virginia, you come to the ED with back pain, you have a 52% chance of getting some imaging. If you live in Utah, there's an 18% chance that they would order imaging on you. So tons of variability. And imaging is specifically not recommended when back pain, with or without radicular symptoms, so radiation to the legs, for example, is present for less than 6 weeks duration. And routine early spine imaging has been shown not to improve patients' pain or function versus giving a course of conservative therapy. And there's also harm from imaging. This increased cost, it exposes patients to ionizing radiation, and it labels patients as chronic low back pain patients. And also, there are some studies that show that if a patient undergoes early imaging for low back pain, they're 8-fold more likely to end up with back surgery. So really not a good thing. In all of these societies, the American College of Emergency Physicians, family physicians, and of course our radiology societies try to dissuade ED providers from ordering imaging in these patients. So when we look at the ACR appropriateness criteria, we have variant 1 here. This is for acute low back pain with or without radiculopathy, no red flags, no prior management, no imaging is appropriate in this population. Furthermore, if we have patients coming to the ED with subacute or chronic low back pain with or without radicular symptoms, no red flags, without prior management, they should not be imaged. So when do we get imaging in these ED patients with back pain? Well, 2 scenarios. So any patient with back pain plus red flag symptoms, or any patient with persistent or progressive back pain over 6 weeks despite optimal conservative therapy, so NSAIDs, PT, rest. So what are the red flags? So any symptoms or historical factors that are suspicious for cancer or infection. So if the patient has a personal history of cancer, unexplained weight loss, fever, immunosuppression, other infections like UTI, IV drug use, systemic steroids, and so on. If there's high concern for spinal fracture, so any significant history of trauma, or sometimes trivial trauma, minor fall, even coughing, sneezing, heavy lifting in an older osteoporotic patient, that may cause a fracture. And of course, prolonged steroid use. And then lastly, if there's Cauda syndrome or other severe neurodeficits, you want to do imaging. And those Cauda symptoms would be things like urinary retention, bowel incontinence, saddle anesthesia, a severe lower extremity weakness, and pain. So what are the imaging findings in patients with back pain? Well, there have been studies that have shown that if you just grab people off the street who are asymptomatic and do MRI of their lumbar spine, a high percentage of them have findings, degenerative findings. So this is the results from one study that showed as we get older, from 20 to 50 to 80 years old, things like disc degeneration become almost ubiquitous in older patients. Disc bulges are also incredibly common. Disc protrusions a little less common. Facet disease and spondylolisthesis also increase in asymptomatic patients. So really the challenge is to try to identify that small subset of patients with low back pain that's likely to have a serious spine disease that needs treatment. So what type of imaging of the spine do we perform? Well, MRI of the spine with or without contrast is first-line imaging in most patients with acute back pain with red flag symptoms. And so MRI is great. It has excellent soft tissue contrast. We can see all the neural structures. We can see the discs. We can see the thecal sac. So standard protocol would be sagittal T1, T2, and some sort of T2 fat sat images, and then axial T2 images through the lumbar spine. And if you have any concern for infection or malignancy, add contrast. And then the one exception is those patients, maybe older patient with low velocity trauma that you suspect a compression fracture, you can get lumbar spine radiographs as your first line imaging study. So let's look at some examples. This was a 35-year-old male with 2 days of back pain and difficulty voiding, decreased anal sphincter tone on exam. So that sounds very concerning, right? So we pull up our ACR appropriateness criteria. This is variant 4, low back pain with suspected Cauda equina syndrome. For initial imaging, you want to get MRI of the lumbar spine. With or without contrast would be appropriate here. Let's look at this patient's MR. Here we can see this extruded disc that's T1 and T2 hypointense. And on the axial images, you can see this disc extrusion has obliterated the thecal sac. It's crushing the Cauda equina nerve roots here. So this was a case of Cauda equina syndrome, and this is due to compression and dysfunction of the Cauda equina nerve roots. And this has classic symptoms of low back pain with radicular symptoms, leg weakness, and then bladder, bowel, and sexual dysfunction. And MRI is your first-line imaging study here. And the most common finding in these patients with Cauda equina syndrome is a disc herniation, usually at L4, L5, or L5S1. But other things that we do see are tumor, infection with abscess, hematoma, and degenerative stenosis. And in these patients, the surgeons need to be consulted for potential decompression with optimal patient outcomes occurring within 24 hours of surgery, or within symptom onset. So let's look at a companion case. This was a 72-year-old female with a history of substance use disorder presenting with hypertensive emergency and 3 days of worsening low back pain and inability to urinate. Here on MRI, we see this convex lenticular collection in the posterior upper lumbar spine. It's dark on T1 and T2, and on the axial images, it's markedly hypointense. And again, we're compressing the Cauda equina nerve roots here. This patient was brought emergently to the OR, and a decompressive laminectomy was performed, and a big epidural hematoma was evacuated. So spinal epidural hematoma, fortunately, is rare. It occurs about 1 in a million patients per year, and risk factors include things like instrumentation, so surgery, trauma, if the patient's on anticoagulants. But note that 50% of these cases are idiopathic. There's no underlying cause for the hematoma. And in those patients, it's believed that since the venous epidural plexus is valveless, perhaps the patient strains or valsalvas or coughs, and that causes rupture of those spinal veins, producing a epidural hematoma. So what we're looking for is a extra-axial epidural collection that's effacing the thecal sac, compressing the Cauda equina nerve roots. 75% of these hematomas are dorsally located in the spine, and the blood signal depends on the age of the blood. So if you remember the old mnemonic, the itty bitty baby doo-doo for blood product age on MRI, if we look here, it's T1 mildly hypointense and it's T2 hypointense. So this would put us at an acute stage of the blood products, 1 to 3 days old. And the treatment here is going to be decompressive laminectomy with clot extraction. So what if a patient with suspected Cauda equina syndrome can't undergo an MRI for some reason? This is a pretty common situation with older patients, pacemakers, cochlear implants. Well, CT myelography is the gold standard. It gives great resolution of the conus and Cauda equina nerve roots. You can rule out compression here. However, we hate doing this. This makes me nervous when I'm on call at night that I'm going to be called in to do one of these myelograms. So is there anything else that we can do besides a myelogram? Well, there might be. There's a recent paper that came out that looked at non-contrast CT of the spine, and what they found was that if you have a high-quality non-contrast CT spine, you can look at the axial images, and if you see less than 50% effacement of the spinal canal, they don't have nerve root compression on an accompanying MRI. So let's take a look at a couple examples of that. So this was a 32-year-old male with acute low back pain. Here on the sagittal and axial CT images, you can see that there's some severe narrowing. There's soft tissue that's hyperdense coming back here. There's greater than 50% effacement of the thecal sac. And then on the accompanying MRI, you can see at the same level, there's severe narrowing with compression of the cauda equina nerve roots. Now look at another patient. This was a 59-year-old female with acute low back pain. And here, at the same level, we can see on the axial CT image, there's clearly less than 50% canal effacement. And on the MRI, the spinal canal is patent, just a small disc bulge. So you might be able to use CT to avoid performing a myelogram. This was a 65-year-old male with history of prostate cancer presenting with 3 weeks of progressive back pain and decreased sensation in his legs. This is going to bring up variant 7 for the ACR appropriateness criteria. So low back pain with or without radiculopathy, one or more of the following: suspicion of cancer, infection, or immunosuppression. For initial imaging, again, we're going to want to do an MRI of the lumbar spine with or without contrast. Probably with contrast, given that history of cancer. And here we are. So you can see there's a burst fracture at L4. There's T1 dark marrow signal. You can see there's a little bit of soft tissue extending posteriorly from that vertebral body with enhancement. And on the axial images, you can see that there's extensive soft tissue extending into the epidural space with enhancement and extending into the paravertebral soft tissues. So this is a case of malignant spinal cord compression. This is a true oncologic emergency, and it does occur in 15% of patients with cancer, most commonly breast, lung, and prostate. And what it's due to is collapse, a pathologic fracture with collapse of the vertebral body with soft tissue and bone extending back into the vertebral canal. And this causes back pain in almost all patients, often with limb weakness, sensory dysfunction, bladder, bowel dysfunction as well. And it's important to treat these patients urgently within 48 hours. So this is an algorithm. If a patient with suspicion of malignant spinal cord compression comes into the ED, you want to admit them, lay them flat, get an urgent MRI of the whole spine within 24 hours. If you don't see spinal cord compression, they're managed conservatively. If there is cord compression, you have to give the patient steroids, 8 milligrams dexamethasone, and then consult radiation oncology and neurosurgery for consideration of surgery with radiotherapy or radiotherapy alone, or possibly palliation in the appropriate setting. So for malignant spinal cord compression on MRI, look at your stir and contrast enhanced images. Look for you want to describe the degree of vertebral body involvement, any posterior element involvement, describe paraspinal soft tissue abnormality, especially in the epidural space, and the degree of bony retropulsion, if any, and the mass effect on the thecal sac. Also, as Dr. Gansler showed us yesterday, look at the cord as well. If these patients have had radiation, you may see radiation myelitis, or there may be signal abnormality from cord compression itself. So in this case, you can see the epidural tumor coming back, and it is compressing that descending S1 nerve root at this L5-S1 junction. This patient was a 53-year-old with back pain, fever, and chills 7 days after lithotripsy and ureteral stent placement. So again, this is going to bring up variant 7 from the ACR, low back pain with or without radiculopathy, one or more of the following. Here we're suspecting infection given that history. So again, we're going to want to do an MRI of the lumbar spine with contrast. So here we are. On T1, we see dark signal, and L1 and L2, we see destruction of the end plates. On T2 and STIR, we see fluid in the disc space. And on contrast enhancement, we see diffuse marrow enhancement, and notice the epidural enhancement here ventrally. On a sagittal CT image, we can see destruction of the bony end plates. And on T2 and post-contrast imaging, we see a psoas muscle fluid collection and enhancement of the fluid within the disc space, as well as epidural soft tissue enhancement ventrally here. So this is, of course, a case of discitis osteomyelitis with epidural phlegmon abscess. And as we learned, this is most common in patients with IV drug abuse, but also older immunocompromised patients get this. The most common organism isolated from these patients is Staph aureus from hematogenous seeding or direct inoculation. And the symptoms really range from back pain, which can rapidly progress to paralysis in short order. And treatment here is aimed at medical management versus surgical decompression. And surgical decompression is usually decided based on whether or not neurologic deficits are present and the degree of spinal instability. Here's a companion case. This was So these are the MRI findings for discitis osteomyelitis and epidural abscess. So for osteomyelitis, you're looking for T1 dark marrow signal, stir hyperintensity, and enhancement. The disc itself will show peripheral enhancement and T2 hyperintensity. And then if you're trying to distinguish epidural abscess from phlegmon, you can take a careful look at the epidural collection. So in the image below, you can see homogeneous enhancement of the epidural tissue. This is what we call phlegmon. There hasn't been liquefactive necrosis. You cannot drain this. You will get no fluid out. As opposed to this upper case here, you can see a peripherally enhancing collection dorsally within the spinal canal with non-enhancement centrally. So this is a discrete epidural abscess. This could potentially be drained. In another patient, an 86-year-old on chemotherapy for bladder cancer presenting with fever, back pain, and inability to walk. Here, we see some stir hyperintense signal within the L4, L5 facets. We can see enhancement within the surrounding muscles, as well as within the facet joint itself. And then there's a peripherally enhancing collection in the dorsal epidural space. So this is a similar process. This is septic arthritis with similar findings to discitis osteomyelitis. However, this also occurs in patients that have had acupuncture or facet pain joint injections. We do see this from time to time, in addition to IV drug abuse and immunosuppression. And your differential for this appearance would include things like degenerative arthritis or inflammatory arthritis. Next, we have an 83-year-old female with acute mid to low back pain after lifting a heavy box. This is going to bring up variant 6 from the ACR. So low back pain with or without radiculopathy, one or more of the following: low velocity trauma, osteoporosis, elderly individual. So here you can actually do radiographs as your first line imaging, but MRI of the lumbar spine without contrast would also be appropriate, or even CT. So here we have the patient's radiographs. You can see there's some deformity of the T12 vertebral body. There's irregularity of the superior end plate and some loss of vertebral body height. Patient had an accompanying MRI, and you can see at T12 that there's stir hyperintense bone marrow edema, and there's a low signal fracture line through the vertebral body. So this was an acute vertebral compression fracture. So vertebral compression fractures are extremely common. There's about 700,000 cases per annum in the US, and they're more common in females than males. However, only 1 in 4 vertebral compression fractures are recognized clinically, since patients often have minimal or no history of trauma. And these have high morbidity and mortality. These patients may have decreased independence and activities of daily living, and they're also at high risk of developing other fractures, hip fractures, and additional vertebral fractures. So can we tell the age of a vertebral compression fracture on radiographs? Yeah, we can with some degree of accuracy. So on radiographs, acute compression fractures are going to show cortical step-offs. They're going to show a condensation band or impaction of the trabeculae, as opposed to chronic compression fractures are going to show height loss, but they'll be of uniform density on radiograph. So I can show you what that looks like. So here we have an L1 compression fracture. Look at the cortical step-off anteriorly, the deformity of the end plate, and look at that sclerotic condensation band. So this is an acute fracture, as opposed to this one on your right. We see that there's loss of the vertebral body height superiorly, but there's more homogeneous density throughout the bone. So this is likely chronic. And then on CT is more accurate for deciding on acute versus chronic compression fracture. And there are 5 CT features that we look for to signify acute fractures. So you're looking for cortical end plate fracture lines and disruption. You're looking for that condensation band, that sclerosis. You can see hypodensity or lucency beneath the end plate. That's a trabecular fracture. If you were to measure an ROI, the density of the bone is going to be higher than adjacent bones due to hemorrhage within the marrow. And then look for any paraspinal soft tissue swelling. That signifies an acute or subacute fracture. So here we have a case, L4. Look at, there's a sharp cortical step off, and there's a sclerotic condensation band here underneath that. You could see on a zoomed up image the step-offs really nicely. This is an acute fracture. As opposed to this other patient, we have height loss, deformity of the end plates, but we don't see any condensation line or frank cortical step-off. MRI is really easy to tell acute from chronic. All the same features apply: cortical step-offs, cortical disruption, vertebral height loss. You can see the trabecular fracture line as a T1 and T2 dark serpiginous line in the bone. You'll often see paraspinal edema on STIR, and then bone marrow edema is key. So only acute and subacute fractures will have STIR hyperintense marrow edema. Acute fractures less than 2 weeks old will have a lot of STIR hyperintensity in the marrow. Subacute, 2 weeks to 3 months old, will have some persistent STIR hyperintensity, but a lesser degree. And then when you're a chronic fracture out over 3 months, the marrow signal is going to return to normal, fatty marrow signal in an adult. So here we have an acute fracture, height loss here, cortical step-off. Look at that STIR bright signal throughout. It's correspondingly T1 hypointense. So this is either acute or subacute. As opposed to this case on your right, we have loss of vertebral body height. You may be questioning whether there's cortical step-off, but look at the STIR. The marrow is completely normal, so this is a chronic fracture. And then we have the question of benign osteoporotic versus pathologic fractures. Dr. Gansler discussed this yesterday, but we'll just summarize some of these findings. So osteoporotic compression fractures occur in 25% of patients, and spinal metastases occur in 15% of oncologic patients. So there's a lot of overlap between these entities. And of course, differentiating between the two is important for both prognosis and management of these patients. So here are the features of benign osteoporotic compression fractures versus pathologic fractures on MRI. So benign fractures look for normal posterior element signal, retropulsion of bony fragments, preserved marrow signal, and a T1 or T2 hypointense serpiginous line. You may see fluid cleft sign, and look for the presence of additional compression fractures. For malignant compression fractures, we're going to see involvement of the posterior elements. Look for epidural or paravertebral soft tissue masses. We'll see expansion of the vertebral body contour. We'll see diffuse marrow placement, ill-defined margins, and check for additional levels of metastases. So we have this 98-year-old male with low back pain after a slip and fall on ice, which is really common in our neck of the woods. So here we have on T1, we can see that there's dark signal, but it's not replacing all of the marrow. There's still some bright signal inferiorly. And then on the axial, notice how there's no involvement of the posterior elements. So we look on the sagittal images, we don't see any retropulsion of the bony fragments into the canal. We do see that area of preserved T1 hyperintense signal of normal yellow marrow inferiorly. And then on your T2 and STIR, notice the serpiginous dark line, that's the trabecular fracture line. And then anteriorly, you can see there's a little bit of fluid on T2 STIR. That's the so-called fluid cleft sign, indicating osteonecrosis. And we don't have any additional vertebral compression fractures, but on the whole, these findings would favor a benign osteoporotic compression fracture, and indeed this was. Now look at this example, 80-year-old male presenting with new back pain and left lower extremity weakness after fall down 2 steps. So let's go through our process again. Looking at this axial post-contrast image, we can see that there's tumor involving the left pedicle, so posterior elements are involved. We can see again this paraspinal and epidural soft tissue mass, so check for that. On the sagittal, notice the bulging of the posterior vertebral body cortex, so that's present. There's diffuse replacement of the marrow signal, somewhat ill-defined. And if you look carefully, we see an additional L5 lesion. So all of these findings point to a malignant compression fracture. So if you're still uncertain whether you're dealing with benign or malignant compression fracture, after you've gone through your checklist, there's a couple of things you can do. And Dr. Gansler showed us yesterday that you can do an image-guided biopsy under CT relatively safely, but that's not appropriate in all patients. Your other option would be to just get a follow-up MRI. Recommend a follow-up lumbar spine MRI in 6 to 8 weeks. If that STIR hyperintense signal is improved, that's a benign osteoporotic compression fracture. If it persists or worsens, then you're dealing with likely a malignant compression fracture. So that's another helpful tool that have at your disposal. So in conclusion, low back pain is a very common complaint in patients coming to the ED, and the majority of these cases do not require imaging. So please do not recommend or obtain imaging in low back patients with or without radicular symptoms if they've had less than 6 weeks of symptoms and they have not been optimally managed with PT, NSAIDs, and rest. And imaging is indicated in the acute back pain setting if red flags are present, like risk factors for infection or malignancy, trauma, sometimes trivial in older patients or osteoporotic patients, and if the patient has severe neurodeficits like Cauda equina syndrome. And MRI is your first-line imaging study, or lumbar radiographs if you suspect a benign vertebral compression fracture. Thank you for your attention. Thank you, John.